The most important question you need to ask yourself upon recognizing a possible difficult airway is, am I and are we equipped and experienced enough to deal with this difficult airway in our centre, or should we discuss with or refer to a specialised centre? For instance, when considering a child for sedation or anaesthesia, ask yourself whether this child has a normal airway. If not, subsequently ask yourself if you have the facilities and expertise to manage the airway safely. If not, and if there is no life or limb saving situation, do not start or stop the procedure and refer to a centre that specialises in management of difficult airways. However, there is always the possibility that you did not expect a difficult airway, or a transfer to another hospital is not an option. In that case, there are a few tips for dealing with difficult airways. First, always call for help. Second, ask yourself, does this child really need an endotracheal tube, or could it be handled with a laryngeal mask airway? Remember that in young children under 1 year of age, a shoulder roll can really help positioning, as well as external manipulation on the larynx using backward, upward, rightward pressure. Always maintain spontaneous breathing as long as possible and ensure an adequately deep level of anaesthesia before attempting intubation. Remember to desufflate the stomach, especially in children with difficult mask ventilation, and last but not least, consider waking up the child when intubation is unsuccessful. An essential part of dealing with a difficult airway is preparation and thorough communication in a timeout procedure where different scenarios and airway plans are discussed with the whole team involved. Make sure you have all necessary materials ready for the various scenarios. This includes different size ventilation masks, oropharyngeal tubes, laryngoscopes with different blades, laryngeal masks, endotracheal tubes in different sizes, and stylets. Also consider using short-acting anaesthetics. There are many different flowcharts available to aid decision-making when dealing with an acute situation and a difficult airway. We will show some examples of difficult airway flowcharts. When primary approach to intubation is unsuccessful, always keep administering oxygen to the patient. Plan A is to optimize your intubation approach. Ensure whether ventilation through a face mask or supraglottic device is possible. If ventilation is possible, realize that you have time to consider other options, your plan B. It is also vital to communicate with the team that adequate ventilation is still possible. In this time, you can try 2 further attempts at intubation, either using a different technique or device, or let the most experienced intubator perform the intubation. Remember to have a maximum of 3 intubation attempts in total before moving to the exit procedures. When these intubation attempts fail, consider waking up the patient, proceeding with mask ventilation or supraglottic device, obtaining expert help, intubating the patient with a flexible endoscope, performing a rigid endoscopy with ventilation endoscope, or, in extreme cases, performing a tracheostomy or cricothyrotomy. When you're in a situation when mask ventilation and supraglottic ventilation is not possible, you are in an acute and life-threatening situation. There is no time for additional attempts of intubation. First, bring the entire team up to speed on the dire situation the patient's in and call for help. Immediately move to the emergency procedures, rigid ventilation endoscope or emergency cricothyrotomy. It is important to develop an airway flowchart in your own centre, according to local protocols and available equipment, in which all involved specialities are trained, and with all emergency telephone numbers on the flowchart.